So one of the other use cases that I've always thought would be very helpful, and there are just some personal cases that come to mind, and also some that I've seen in M&Ms, are when you have a patient that's severely coagulopathic, and you put you put a covered stent in, but that doesn't occlude, and then you try packing that vessel, and that doesn't thrombose. Is that something that you guys have seen in your practice, or something where you've been leaning heavier on liquid embolics
Oh
for?
yeah, we've all been there, right?
Yeah,
I
yeah,
mean,
yes.
you're filling the space with coils. You think you've done a great job. You inject a little bit of contrast, and it just flows right through your coil pack. And that really relates to what I just said. It's hard to fill the majority of the space with a mechanical agent like a coil. And so even if you do the best job and you have the tightest coil pack imaginable on fluoroscopy, there's still gaps that are difficult to perceive, and you can appreciate those when you inject contrast and it still goes through. In order to fill the rest of that space, you're counting on the patient's ability to form clot. That clot has to occupy the space in between those coil loops. Now, thankfully, it happens in most patients. So it's not that much of an issue, especially when you're using fibroid coils, let's say, because that even, prompts more clot to form. But like I said, we've all been there where it just takes a long time. Liquids are a great adjunct to that. It'll fill those gaps in a way that's not dependent on the way patients can or cannot clot. And that's either with coils or just without coils as a de novo agent. If you just take a vessel and embolize it with a liquid, it'll fill the space, and you don't have to worry about the patient's ability to make thrombus.
Okay. So I kind of put out one of the ways in which I thought having a liquid embolic as a tool in the tool chest would be helpful. But just curious of how you guys are practicing at Albany. What cases are you using your liquid embolic for?
Well, I think first and foremost, we're looking at peripheral hemorrhage. So we see a lot of trauma here. It's a busy level 1 trauma center. And I think when we see active bleeding on a trauma angio, so let's say pelvic angio, renal angio, anything like that, we're very quick to grab liquids. And so I think that the DMSO-based liquids, like lava, for example, does a really nice job at being able to administer it quickly and to maximally fill the space and stop bleeding quickly. Now, I think all of us in a quiet moment would probably argue that we're really fast at what we do. But no matter how fast you are, it takes time to put in multiple coils. And as people who put coils into vessels, it's pretty rare to have one coil occlude a vessel. So it's normally a couple of coils, and that just takes time. But grabbing a liquid and putting it through a catheter that's appropriately positioned, even if you're injecting it very slow, and for lava, we do advocate that it be used very slowly. The reality is that you're still going to be faster than putting in multiple coils. And therefore, in a patient who needs us to work quickly, this is probably one of the fastest ways we can accomplish that goal.
So one of the things I wanted to unpack, Gary, was DMSO. Like you mentioned DSMO liquid, and I was curious of how that plays into lava.
Yeah, so DMSO, it has two roles when it comes to the use of products like Onyx or lava. It's a component of the embolic itself. So the reality, it's just part of the material, but it's also a solvent that we put into the catheter almost like as a primer before we administer the embolic. So we're greasing the wheels, for lack of a better word, right? We're understanding what the internal volume of the catheter is. We call that the dead space volume. If you look into the instructions for use for any of the microcatheters that you use, you certainly want to make sure that they're DMSO compatible. And you also want to understand what that volume is. So we will fill that space with DMSO and then follow it with the embolic. And that really prevents any of that from polymerizing or precipitating in the lumen of the catheter. And it allows us to inject it a little bit more easily into the target vessel.
Okay.
So it's an important component of what we're doing, both as part of the product and as part of the process of injecting it.
Okay.